Hello, everyone, and welcome to our lunch session. We are very excited to have our special guest. We have Alec Kassin, and he is an amazing coach talking about a pain-free life. And there's so much more to what you're going to hear today that we wanted to provide at your lunch hour. Again, eat your lunch, jump in and out. This is being recorded. We want you to enjoy this. And again, we want you to enjoy your lunch. So this is going to be a fabulous presentation you're going to hear. Ask him questions. He's going to be in and out. Alec, go ahead and take it away.
Awesome. Jennifer, thank you so much. Everybody, it's good to be with you all. I'm gonna hit share my screen here. And I want to make sure, is everybody able to see my screen? You get a thumbs up in the chat or something. Some feedback, make sure that you guys can see this okay. Oh, okay, I got a yes. Thank you. All right. Well, everybody, I'm delighted to be here. And my goal for the next 60 minutes is for you to never see pain, chronic pain, and the treatment of it the same way again. Now, my name is Alec Kassin. I'm a certified chronic pain coach and the co-founder of Pain Free Comeback. Now, I'm guessing that you come across chronic pain quite often in your work, either a patient who comes in with chronic pain symptoms that seem to defy test results or symptoms that haven't responded to treatment despite a pathology. Just put a yes in the chat if the organization that you works for comes across chronic pain on a regular basis. Just put a yes in the chat. Yeah, lots of yeses. And I'm also guessing that these patients can be some of the most challenging, right? The ones who aren't responding to treatment, the ones who require a lot of time, effort, and energy. Well, that's what we're going to talk about today. And my organization, Pain Free Comeback, we specialize in helping athletes and active people with slow recoveries, poor responses to treatment, and persistent symptoms to make a pain-free comeback. I'm a former semi-pro cyclist. My teammates included national and world champions. I also spent 5 years in the tech world. I worked for LinkedIn. I was a manager there, and I gave up that career in order to pursue this calling. I've been a certified chronic pain coach for about 3 years. I've been trained by and worked with chronic pain physicians from Cedars-Sinai and Michigan State. And I've had the honor and the privilege to work with Ironman champions, state champion cyclists, NCAA Division I college athletes, American Ninja Warriors. I've seen some pretty incredible comebacks, pretty incredible experiences. Now, all that's important, but I really want you to know that this is deeply personal to me. Because when I was 18 years old, I wanted to be a pro cyclist. That was my dream. My life was eat, sleep, breathe, cycling. And about 10 days before I was going to do a race that Lance Armstrong had won 2 years prior, I developed debilitating back pain when I was out on a training ride. It was like my back completely locked up. It's like somebody was twisting my spine from end to end. It was so bad. Went to a chiropractor, and the chiropractor said, "Don't worry, in 2 weeks, you're going to be back on top." 2 weeks turned to 3, turned to 4 and 5. I tried all these physical treatments, but I wasn't getting better. And pretty soon, I found myself in constant pain from the moment I woke up to the moment I went to bed. I had to withdraw from college for a year because I couldn't sit in my lectures. My life went from being an active and aspiring cyclist, professional athlete, to somebody who was partially bedridden, depressed, on opioids, and with suicidal thoughts. And I was diagnosed with a ruptured spinal disc, L4, L5, and a herniated L5S1. And you can see my MRI there from 2011 when this happened. Now, thankfully, I've been pain-free and unrestricted for over a decade, doing 500-mile bike trips, backpacking without issues, doing back bends, and I have no pain. Okay, actually, friends, I just lied to you all about one thing. Now, it's true that I was a former semi-pro cyclist. It's true that in 2011, I was diagnosed with a ruptured spinal disc. It is true that I have not been in pain for 13 years. But this is not my MRI from 2011. This is actually my MRI from last year when I was pain-free. You see, after I had my recovery, I wanted to understand, do I still have the same pathology? Do I still have the same ruptured spinal disc, even though I haven't been in pain for over a decade? And I was living in the UK, and I paid for an MRI out of pocket because I didn't have any pain. They wouldn't, give me a referral. And this is the report. And you can see at the bottom here, you see the L4, L5, and L5S1, same pathologies, a posterior disc bulge with a central protrusion and annular tear. And at the bottom, it says, overall, the appearances are essentially unchanged from the previous report description. Now, in 2011, I had debilitating pain and an MRI that showed a ruptured disc. In 2025, I have no pain and an MRI that shows the same pathology. Now, I am not an anomaly. People just like me are healing left and right from months, years, decades of chronic pain without correcting structural pathologies. They're using a scientifically validated approach used by physicians across the country. And that is what we are going to talk about today. So, this is our agenda. We're going to make this interactive. We're going to talk about the chronic pain crisis today. I'm going to give you a new way to understand and treat chronic pain and share how this applies to you and your work. Sound good? All right, let's dive in. So, the chronic pain crisis today. There's a paradox. Despite tremendous recent progress in medical science, why is there a chronic pain epidemic? And by an epidemic, this is what I mean. It's bad. Chronic pain is more prevalent than other chronic conditions in the US. It's more prevalent than diabetes, cancer, and heart disease combined. About 50% of American adults suffer from chronic pain. 5%, that's roughly 13 million American adults, suffer from high impact chronic pain, meaning their lives are essentially upended. It's also incredibly expensive. The annual cost of chronic pain has skyrocketed. We spend over $636 billion a year on the treatments of chronic pain. And by and large, it's getting worse. Chronic pain is increasing across the board. There's a study that was done that showed that pain is increasing across all age groups, demographics, all types of pain, from migraines to back pain, knee pain, neck pain, etc. People today are feeling more pain than those the same age did in past decades, and each new generation is reporting more pain than the one before it. And by and large, the conventional treatments that we have for chronic pain aren't incredibly effective. And this is a clip from a 2016 film featuring Andrea Leonard Segal, who is an MD and member of the American College of Radiology. She works at George Washington Medical Center, and she's going to talk about some of the treatments as it pertains to chronic pain.
We would be recommending certain physical therapy modalities like physical therapy or ultrasound, and it never made sense to me, but I was doing it because it was recommended. And then I started looking at the literature, and I realized that the literature that was written and published in medical journals that supported our using these different modalities really was exceedingly weak. The studies were small, they were not well designed. This firm ground upon which we were basing our recommendations for patients was not very firm indeed.
Now, I want to be crystal clear. There is absolutely a place for physical therapy and physical treatments for acute pain issues. For example, I broke my wrist. You can see I have a scar there. I had a plate that was put in by an excellent surgeon and had it taken out later. I have no issues with this wrist. I required physical therapy. I required a lot of help in order to get this wrist back to normal. But when it comes to persistent chronic pain, pain that has lasted for months, years, decades, despite physical treatments, a lot of what we have isn't working very well. And this is what I mean. There was a study done in the UK in 2021 that showed pain medication, there's little evidence that it has helped make a difference to people's quality of life or pain or psychological distress. A lot of the physical treatments, the Lancet in 2011 shared that currently available treatments only provide minimal improvements in physical and emotional functioning, modest improvements in pain. And when it comes to lumbar fusion surgeries, when it comes to treating disc degeneration, herniations, it's associated with an increase in disability, opiate use, prolonged work loss, poor return to work status. Now, once again, there's absolutely a place for all of these things. But when it comes to chronic persistent pain, the data shows that we're not doing very well. And people are fed up with it. 33% of Americans trust the medical system, according to a recent Gallup poll. Visits to unconventional therapy exceed visits to primary care physicians. Now, that should worry all of us, right? Now, we can talk at a high level about the statistics and what this means for the country, for the medical system. But there's also a deep personal impact as well. And this is from a recent film called This Might Hurt. It's a film about chronic pain. And you're going to be introduced to Kim, who has battled chronic pain for 8 years.
I went into work early one morning and I was sitting at my desk and I went to stand up to do something and dropped back in my seat. I called my doctor right away and got in and found out that I was having spasms. I've had 3 abdominal surgeries trying to alleviate the pain. Hysterectomy, colostomy, ileostomy, but then the pain came back. I've been bedridden due to chronic pain for 8 years. This is my bag of medicine. This is Lyrica. It is for fibromyalgia. Halfway through the 8 years, I was diagnosed with fibromyalgia, which is all over, aching, fatigue. Time to make dinner.
It is heartbreaking to see this. Think of a patient you've seen or somebody in your life who represents Kim. Somebody who hasn't been able to find answers. Maybe it's a loved one. Maybe it's even yourself. Notice what that feels like. It does not feel good to not be able to help people like Kim, to see people like this that are stuck. So something is clearly broken. And there's a fix. That's what I'm here to talk about today. So let's talk about a new way to understand and treat chronic pain. And by the way, for full transparency, I am not a doctor. I do not pretend to be one. Throughout this presentation, you are going to hear from doctors, neuroscientists, neurologists, sharing scientific validated studies on this topic. So you don't need to trust me, trust them. Listen to the science. So I'm going to share a new way that the medical world is starting to view pain. And this video is from the Association for the Treatment of Neuroplastic Symptoms, or the ATNS. You're going to hear medical professionals, neurologists, neuroscientists talking about the surprising new science of pain. Take a look.
I'm Dario Zagar. I'm a neurologist with Yale University.
I'm Dr. Becca Kennedy. I'm former lead of the Long COVID Clinic at Kaiser Permanente Northwest.
I'm Yoni Ashar. I'm a neuroscientist at the University of Colorado.
All pain is real, and all pain is generated in the brain. These things are revolutionary ideas.
There's new science about how pain is made. Pain is not made out in our body by our nerves.
So if you put your hand on a hot stove, the hand actually sends signals up through the nerve pathways into the brain.
The brain picks up on that neurochemical message and then begins to communicate with other parts of the brain saying, hey, I think we've got a problem here. We need to pay attention to this.
Most of the time, the brain does a pretty good job at letting us know when there's a threat or injury to the body and creating pain to protect us. You know, don't touch the fire, it's hot. But sometimes the brain gets confused.
I think it's helpful to think of the idea of safety and threat.
We now are learning that pain is really a protector. It's a signal from the brain that we are in danger.
And that when it feels like it is under threat, which may happen because at times it was, it can continue to perceive sensations or feelings or experiences as being threatening.
Pretty incredible, right? So the key takeaway here is that pain is a protector. It is the brain's way of trying to protect us. Now, we didn't understand for many, many years how this worked, and now we do. We focus so much energy on trying to get rid of pain or trying to mask it. And because of our old understanding of how pain works, we didn't realize that sometimes there isn't a mechanical, structural, or pathological issue at play. And this can perpetuate the pain cycle. Now, some people have lived this firsthand. You know, Natasha, your story in the chat here is heartbreaking of chronic pain. So there are people on this call right now who are dealing with things like this on a day-to-day basis. And when we start to understand the brain's role in pain, it gives us so many more tools to be able to create a breakthrough. So when it comes to, meds are a big part of it, aren't they, Natasha? So when it comes to chronic pain, there's a few myths that I want to share. One is that it's always the result of physical damage. Actually, many people have chronic pain and no damage or injury. Second myth is that abnormalities that you see on an MRI or an X-ray always lead to pain. In fact, abnormalities can often be present in people with no symptoms. Third myth, we need to fix the body in order to heal the pain. Sometimes that's true. My broken wrist absolutely needed to be fixed. But when it comes to chronic pain, neuroplastic treatments, which we're going to talk about, actually outperform physical treatments in many ways. Finally, this myth that it can only be managed. We talk so much about pain management, when in reality, hundreds of thousands of people have been helped and cured by a neuroplastic approach. Let's talk about imaging for a second, right? And I'm under no illusion of the audience that I'm speaking to. But if I were to ask you, what percent of people with no back pain at all have a disc bulge? If we were to take an MRI of the people who have no back pain at all, what percent of them would you say have a disc bulge? Put it in the chat. What's your guess? What percent of people would have a disc bulge? 15%, 50%, 70%, 45, 25, 80. Yeah, there's some good guesses here. 64%. 64% of people with disc bulges and protrusions have no back pain. That was in the New England Journal of Medicine. Now, I work with athletes, and this one is incredibly mind-blowing. 40% of pro tennis players that were examined have partial or full thickness tears of their rotator cuff and no symptoms. No pain, no loss of power, strength. 40% of people have nerve damage consistent with carpal tunnel and no pain. Now, one of my favorite stories of this is Michael Porter Jr. Anybody a basketball fan in the chat? Michael Porter Jr., he played for the Denver Nuggets. He was actually just traded to the Brooklyn Nets. And he has a pretty incredible story. He was diagnosed with degenerative disc disease in 10th grade. He had 3 back surgeries by the time he was 25, and he had never played a full season due to pain. He was treated by some of the world's best sports medicine doctors. Despite that, his pain persisted, and after his 3rd surgery, his career was in jeopardy. And that's when he turned to a neuroplastic approach. And guess what? It worked. For the first time in his career, he played an entire season without missing a game because of his back. And he has this quote. It's a pretty striking one. Every single NBA player they would MRI would have bulging discs, probably degenerative discs, herniated discs. Some players would be symptomatic, some players won't. That's not what's causing your pain. And this is a guy who's making $200 million, who had the best sports medicine treatment that money could buy. He wasn't able to get better until he turned to a neuroplastic approach. Now, you might be asking, okay, are you saying that the pain is all in my head? The answer is absolutely not. This pain is real, just as all pain is real. People who have chronic pain, like I did, they're not sick, they're not weak, they're not lazy, they're not imagining it, they're not consciously deciding for this to happen. And when the key takeaway is that this is not your fault. And when your brain is involved in creating chronic pain, as it is in most people, it's a very good thing because it means we can unlearn pain. Because there's a fantastic book that came out a few years ago called The Way Out, written by Alan Gordon. And it leveraged a lot of neuroscience talking about the brain and pain. And a key takeaway is that chronic symptoms are associated with pain regions that are responsible for learning and memory. Now, if let's say you sprain your ankle playing basketball, you would have if you were to get an MRI, an fMRI, you'd have brain activity that's associated with the pain processing parts of your brain, the ACC, the thalamus. But if you, let's say a year later, still had pain in that ankle, the parts of the brain that would light up would be different. It would be the medial prefrontal cortex, essentially the parts of the brain that are associated with learning, memory, and meaning making. So one key thing that we've learned about chronic pain is that the same mechanism that allows you to know how to hop in your car, to know how to operate a steering wheel, to turn your turn signal, to operate the windshield wipers unconsciously. That habit that you formed, that's the same mechanism that is at play with chronic pain. It is essentially, there's a large component of it that is learned. Now, let me pause for a moment. There's a lot that I'm throwing at you. And I'm just curious, are you with me? Now, on a scale of 0 to 10, 0 being, no, this is complete BS, 10 being, I am completely on board. Where are you at with this? I'm really curious. Put it in the chat. 10, 9, on board. Okay, people are getting this. And if you're not, that's perfectly okay too. Awesome. Great. It's great to see this. Thank you, everybody. And if there are questions and things that you want to share, there's going to be time at the end for Q&A, so don't worry about that. Okay, so what works? What is a neuroplastic treatment? So there's 2 scientifically validated approaches that have been delivering amazing results for people in pain. The first one is called PRT, or pain reprocessing therapy. It's a program that helps retrain the brain to interpret pain signals as safe and not dangerous. It helps to break the chronic pain cycle through education and somatic techniques. And the focus is on emotional processing and positive affect, essentially creating safety in the body. because as we know, if you have chronic pain, there's a lot of feeling unsafe in your body, movements feeling unsafe. And that's what PRT helps with. There's also emotional awareness and expression therapy, or EAET. EAET is fantastic for identifying, processing, and expressing emotions. It's especially useful after traumas. There's a large link between trauma, adverse childhood experiences, and adult traumas and chronic pain, as we'll talk about. And it's a mix of exposure therapy and emotion-based therapies. And here's some of the data that are supporting these treatments. There's a study called the Boulder Back Pain Study that came out in 2011 in the Journal of the American Medical Association. They took people who had an average of 9 years of chronic low back pain, 9 years on average, and they put them through 4 weeks of pain reprocessing therapy. They also compared it to a placebo and standard treatment. The standard treatment, about 10% of people were pain-free as a result of that. 20% of people got better with a placebo. 66% of people who did pain reprocessing therapy for 4 weeks were pain-free. Those results held after an entire year. The results stuck. Once again, this is a population who had an average duration of 9 years of back pain. I'm going to share a clip from a movie called Pain Brain that talks about this study, talking about pain reprocessing therapy, or PRT, and what allowed people to get better. Take a listen.
2/3 of patients randomized to PRT were pain-free or nearly so after treatment.
Usually the pain, it's a couple of minutes, I kind of think about it, and then I go about my day. It usually doesn't come back, so.
Well, most days I have no pain at all. I still have maybe a little stiffness if I've been sitting in a chair and working for an hour.
It definitely, like I said, makes me look at pain totally differently.
After a couple months talking to Alan, it was pretty much gone.
Before treatment, basically everyone believed their pain was due to injuries or sitting or bad posture or degenerative disc disease. After treatment, suddenly people were telling us a totally different story about what was causing their pain. They were saying it was due to stress, to neural pathways, to anxiety, to their life history. And what we found is that the more people shifted in what they believed to be causing their pain, the more they had a pain reduction.
What I found was really interesting was it wasn't just helping me with the pain, but it felt like it was helping me with other things that I was dealing with, like anxiety or stress or things like that.
It was a dramatic reconceptualization of pain.
The more people shifted what they believed was causing their pain, the more their pain decreased. And these are people with herniated, bulging, degenerative discs, facet joint issues, getting better without having to treat those issues. Incredible stuff. And as somebody who suffered from back pain for 2 years, it's heartening to see what is possible and that this is starting to make it into the mainstream. I want to talk briefly about emotional awareness and expression therapy. So I'm curious, how many of you work in a practice or clinic or an area where you send people to cognitive behavioral therapy, CBT, for treatment of pain or anxiety or depression? Just put a yes in the chat if that's something that that you're familiar with, using cognitive behavioral therapy for these things. Yeah. So with emotional awareness and expression therapy, there is a fantastic study done at the VA where they took a population of older male veterans who had chronic pain. A lot of them also had PTSD, anxiety, and depression. They put them through 10 weeks of EAET. It was 126 participants. What they found is that 17% of those who did CBT, what they were comparing against head to head, 17% of them achieved a 30% pain reduction. Not bad. When it comes to EAET, 63% had a 30% pain reduction. And about a third had a 50% or more pain reduction. Emotional awareness and expression therapy also beat out CBT for anxiety, for depression, for PTSD. Incredible to see what is possible when it comes to healing. Now, when it comes to treatments, I and the doctors that and medical practitioners that I work with have seen some pretty incredible recoveries from a lot of structural issues. So herniated, ruptured, degenerative discs, scoliosis, spinal stenosis, fibromyalgia, carpal tunnel, tennis elbow, plantar fasciitis, labrum tears, rotator cuff tears, RSI, thoracic outlet syndrome. And then non-pain-based issues as well. IBS, migraines, vertigo, nausea, tinnitus, chronic fatigue, and even long COVID. Healing is indeed possible. I've seen it in the clients that I've worked with. I've seen an Ironman triathlete suffering with ankle, knee, elbow, and back pain for months become pain-free and become an Ironman champion. A 59-year-old woman who had a hip replacement because she had chronic groin pain. She was restricted to doing grocery shopping on a scooter, become pain-free in 3 weeks and walk 13,000 steps, feel well enough for the first time in 2 years to visit her family who are an international flight away. I've seen a 55-year-old man who was on sick leave from work, who had 30 years of chronic pain throughout his whole body, who couldn't walk more than 5 minutes without pain, run a marathon. I've seen this with my own eyes, things that seemingly defy conventional wisdom, and yet it is happening. And you can see it with your own eyes too. We're going to return to Kim. You remember her? She was in the video. She's the one who had all the surgeries and was taking all the medications. This is her after going through a neuroplastic treatment program. Take a look.
It's just amazing, the changes. I've gone from laying in the bed, having very little interaction with the outside world, to I now have a job. I'm working part-time. I love it. I am an event coordinator. My job is to raise money for Samaritan House so that we can put food on the shelves. I still occasionally will have intestinal spasms.
Okay, pull me away.
But I can't remember the last time I took more than 2 Tylenol. I no longer try and stuff every emotion down. You let them out, you deal with it, and you move on.
Let me take my stuff down.
And I love helping people. We all need help now and then, but I'm not the one who needs all the help. And it is an awesome feeling.
Pretty incredible, huh? It's almost like she's not the same person. And these recoveries are possible. They are happening. She had 3 surgeries, 8 years of chronic pain, fibromyalgia, and look at what she's doing. All of this means, in my eyes, millions of people are living in pain and do not have to be. That we have an opportunity to change the conversation about chronic pain and give people hope where they haven't had any. So, let's talk about how this applies to you and your work. Now, Stephanie, you asked a really good question in the chat. How do you find a provider that uses a neuroplastic approach? I'm going to talk about that because that's one of my goals, is for you to be able to know where to go to get these resources. So, how does this apply to you and your work? And I'm aware that there's different types of influence that you all have. You're in different roles in the organization. You're not always interacting with patients directly. But I want you to be aware of this. There's some important key parts here. But let's address the elephant in the room. The interventions that I am sharing with you, neuroplastic approach, they're not as lucrative as surgery or some other physical inventions. And if you are a surgeon or you work for one and you're questioning whether surgery is actually needed, yeah, that's potentially lost revenue. I'm not going to sugarcoat that. But being aware of this and allowing people to pursue a neuroplastic approach when it might help them means fewer denials, fewer malpractice cases, and a more efficient, effective care strategy. You're helping people get better. It means more fulfillment for you, less burnout, not having to deal with the 40% of cases that walk in your door that seem to defy treatments or defy medical imaging. So with that said, the goal here is to distinguish between chronic primary pain, neuroplastic, and chronic secondary pain, which is caused by a structural injury or a disease. Now, let's talk about the difference between these two things. So diagnosing chronic primary pain. There was a study that came out in 2023 in the Journal of Pain that has a validated approach to being able to differentiate between pain that is generated exclusively by the brain and pain that is due to a structural abnormality that somebody, or structural issue that somebody is presenting. What they did is they took about 222 people in Lake Charles, Louisiana, and they came into a clinic for non-specific low back pain. It was non-segmented. So basically they took anybody who had low back pain. And this is, they essentially compared the findings on somebody's imaging, their x-rays, their MRIs, with their symptoms to say, did they match? If somebody has a disc bulge on the left-hand side, are they having symptoms that are associated with those nerves or on the left side, for example? What they found is that about 5% of people had exclusively secondary pain, meaning the pain was directly attributable to the anomaly that was showing up. About 7% had mixed. They had primary and secondary pain. 88% of people had primary pain only, which was neuroplastic, meaning their abnormality had nothing to do with their symptoms. Maybe they had back pain on the left, but a bulge on the right, or weakness in an area that had nothing to do with an area that was being affected. This is despite the fact that 98% of people in this study had at least one spinal anomaly on their imaging. Once again, in only 12% of cases was it due to that actual anomaly. This is in the Journal of Pain. What they did is they used this criteria called the FIT criteria, which stands for functional, inconsistent, and triggered. And this is a way for physicians to be able to rule in neuroplastic pain. Now, it's really important that this occurs after the scary things like fractures, infections, tumors have been ruled out through a comprehensive exam. When it comes to the FIT test, though, you're looking to see if pain is functional, inconsistent, and triggered. Functional meaning the symptoms affect the function but not the structure of the body. So maybe the symptoms radiate to cover an entire body part. Maybe they are occurring in different parts of the body at the same time. Maybe the symptoms are persistent despite a lack of injury or long after an injury should have healed. Inconsistent means they shift from one location to another. They might have a symmetric pattern. Maybe they're worse after physical activity as opposed to during. Things that aren't necessarily consistent, right? Finally, triggered. Are there triggers of food, time of day, light physical activity? Thinking about a trigger or even anticipating a stressor, does that lead to symptoms? Now, not all of these need to be present in order to rule in neuroplastic pain. Even just one of these is enough to do so. So this is a key tool that the providers who are working in the space are using to help differentiate between pain that is caused by a structural issue and neuroplastic pain. So when you are looking at medical records, if you are or looking in documentation, you've probably seen this stuff in reports, right, for your entire career. So some clues to be able to uncover this, to be able to have that view of the documentation you're looking at and to see whether the symptoms might be neuroplastic. If the symptoms have gone on for longer than 4 months, maybe there's no apparent injury. Imaging might be unremarkable. Short-term or an absent response to treatments. If the symptoms are triggered by stress, they shift from one location to another, they spread to different body parts. These are all signs that you can look for in documentation to be able to assess whether neuroplastic symptoms are at play. Here's the other piece of this that's really important. This video is featuring Matthew Lieberman, who's a neuroscientist at UCLA. He's Harvard trained, and he's going to explain a link between physical pain and emotional pain. Take a look.
The research that we've done in my lab and in other labs has discovered that when we are socially rejected, when we feel social pain, the brain looks very much like it does when you feel actual physical pain. So if you were to sort of feel a shock on your arm, there's this characteristic pattern in the brain that would be associated with you saying, ouch, that really bothers me. And that same pattern would come online when you were playing a game and 2 other people left you out of the game for no good reason. And it seems like a minor thing, but it would activate the same region. And here is the really surprising thing. If you take paracetamol, or in the US what we call Tylenol, it makes these effects go away. It'll make the physical pain effects go away, that we know about, but we and others have found that it will make the social pain effects go away. The brain response will change, our experience will change, and that's pretty surprising, but it speaks to how deeply wired this biological need for social connection is, that the brain really treats it as a kind of pain.
Emotional pain can lead to real physical pain. And if you or the physicians that you're working with talk to these patients, understand their full history, we'll start to see patterns, symptoms arising in periods of stress or major life changes. And this is not just psychological stuff that we're talking about, real physical changes as the result of emotional issues. So the second tool that you have, first tool is the fit criteria, being able to differentiate between neuroplastic or primary and secondary pain. Second tool is patient history. So looking at the type of people who are susceptible to neuroplastic symptoms. Certain personality types, perfectionistic, people-pleasing, catastrophic, being hard on yourself, worrying. I associate myself with a lot of these. And some of them, if I'm being honest, I still have. If there's a stressful event or life change that happened around the time of the condition. For me, it was a lot of pressure that I was feeling to perform well in my first professional races as a cyclist. If you have a history of ACEs or adverse childhood experiences, traumas, it can sensitize the brain, the nervous system to perceive threat and danger in a more elevated way, in a more sensitive way. If you have a history of other physical issues that seem to defy medical imaging or treatment, constipation, ulcers, gastritis, reflux, hives, eczema, tinnitus, etc. History of mood symptoms like depression, anxiety, or other mood symptoms. And finally, if no treatments have proven effective. These are all things that doctors, medical practitioners in this space are looking at to look at the whole person to see, is there a way that we can treat these symptoms without invasive measures? Now, when it comes to coding specifically, now I'm not a coder, and admittedly, I had to do a lot of research in order to feel competent to share this stuff with you. I spoke with Dr. David Schechter, who he's in family and sports medicine. He's on the medical staff of Cedars-Sinai. He's been practicing for 30 years, and he treats both structural issues as a family and sports medicine physician, and neuroplastic. He was named a top doctor in LA Magazine, Men's Health Magazine, and US News and World Report. And he has a few tips for coding when it comes to primary pain. Key insight: document structural findings and the brain psychological findings, right? He says, use the codes that you are already using to look at the structural, and also add F45.42, other pain disorders related to psychological factors. When you put the physical diagnosis first and the psychological diagnosis second, when you include the psychological diagnosis, this links to the brain, the emotions, and it makes for an easier referral to psychotherapy for the people who are working intensively with people using a neuroplastic approach to help get them better, right? It makes it easier for you to refer them to people who can help. Ultimately, by doing this, you have an opportunity to make a difference in the life of your patients. And what's coming down the pike is something really exciting as well. In the ICD-11, there is actually a designation for chronic primary pain. Essentially, pain that does not have a structural pathological diagnosis. So this is coming down the pike. Now, as we start to wind this down, I want to share one last video talking about physicians and medical professionals who are talking about their experience treating this and calling out how different it is. Take a look.
You know, it's understandable to have doubts about this. This is new science. What we're doing here is on the forefront of biomedical science. But the studies that are coming out and the research that is growing and being published, the results are just phenomenal. People are recovering from all kinds of chronic pain, long COVID, all kinds of chronic symptoms.
Migraines. Chronic fatigue syndrome. Post-concussive syndrome.
Symptoms blamed on chronic Lyme.
Sleep sensitivities.
Dizziness.
Pelvic pain.
POTS.
Fibromyalgia. Sciatica.
Bladder pain.
Digestive problems.
Plantar fasciitis.
Tremor.
Brain fog.
IBS, skin disorders. I could go on and on and on.
It's the biggest blind spot in healthcare, and it's a problem that's got a solution.
And the beautiful part of this is when it's a nervous system problem, we can help you.
Hi, I'm Dr. Matt McClanahan, and I've successfully treated hundreds of patients.
I have seen hundreds of people healed from these methods.
Probably at least 80%.
80% to 80%.
The majority of my patients.
The majority. Hundreds of patients.
Hundreds of patients.
Thousands.
Dozens.
Over 7,000 people successfully improved.
I have thousands and thousands of people who were formerly hopeless that are completely well.
This is a paradigm shift in thinking. It is a radical new way to think about the body.
A lot of this is so counterintuitive to everything we've ever done.
My patients tell me this is a real revolution.
So counterintuitive to everything that we've done. But it's possible. And that these physicians, just like you or the physicians that you work with, want to do right by their patients. That's what led them into this approach that is literally changing lives. And for me, going back to my story, this is the approach that I used in order to get better, to resolve 2 years of chronic back pain. And while I didn't go on to become a professional cyclist, I did return to the sport just to prove to myself that I could. And even though in the darkest depths of the pain that I experienced, I would have given anything for it to be over, looking back on it, it gave me my life's purpose. And I'm so grateful for the experience. And it truly has been a gift. And witnessing so many people who have never believed, who would have never believed that they would get their lives back, as I did, actually make incredible comebacks has left me with an unshakable belief that our biggest setbacks can turn into our greatest comebacks. So, let's recap where we've been. Chronic pain, it's a crisis, but it is one that has a solution. Pain is not an enemy, it is a protector. Whoop. Pain is not an enemy, it is a protector. Neuroplastic treatments like PRT, pain reprocessing therapy, and EAET are scientifically validated, and they are helping. And you can help. You can diagnose primary pain using the FIT criteria and take a detailed patient history and share this information with your patients. So in terms of what to do next, I've put together a handout. I'm putting it in the chat there. It's also available in the Google Drive that has a takeaway of the talking about neuroplastic symptoms, about tools to rule in primary pain, some of the coding tips that I shared, as well as many different resources, books, films, organizations. Take a look at that handout. And what I encourage you to do is, if you're a medical administrator or coder, talk to the medical staff that you work with about neuroplastic treatments. Give them this handout. If you're a physician, look into neuroplastic pain treatments and how to help your patients. You can train to do this. You don't have to refer out. This can be something that is lucrative for your practice. And I encourage you all to visit symptomatic.me. It is the website of the Association for the Treatment of Neuroplastic Symptoms. They are a fabulous organization filled with medical practitioners that are helping people get better from symptoms just like this. And they have a conference in Boulder in the fall as well. So with all that said, thank you so much for listening, for your participation, and I'm here to take questions.
Thank you, Alex, so much. I am very excited. I mean, like, I just learned so much. My husband had a disc slip several years ago. He every once in a while has a problem. Like right now, he's down again with his back. And so it's just this like it's very meaningful to me too, just to think about what options we might have to help him with that. It doesn't happen every day, but he does deal with it off and on. So I mean, this is just personal, and then it's also good for physicians, I think, to know about from a reimbursement standpoint, but also from, hey, you know, I want to focus on these patients I can actually fix with physical medicine. Let's talk about how we can help these patients with these other areas. So this is great stuff. Any questions, anybody? I mean, we've got a few minutes here before we switch over. Or you guys can, of course, use the form that we have in our drive to submit questions if you think of them later, and then we'll make sure all of our speakers have access to the questions that you direct to them. And we are creating an FAQ document for our attendees that we'll release after the conference. So no question goes unanswered. We will make sure that all questions get answered. All right. Well, thank you so much, Alec. This has been so wonderful.
Thanks, Jennifer. If there aren't any questions, I'll just share a couple of things. So number one, if you go to my website, painfreecomeback.com, there is a whole bunch of resources that I have of breakthrough stories, scientific studies, podcasts, books, films, etc. There's also a test, a comprehensive test that I've put together in consultation with the doctors, the medical professionals that I work with, to help people come to their own conclusion about ruling in neuroplastic symptoms. And that's right at the top of the website. And if you have any questions, feel free to, put them in the FAQ, send me an email, connect with me on LinkedIn. I'm here to help and happy to help.
Excellent. Well, thank you for attending. We have a couple minutes to jump over to our live panel for revenue cycle management. This is our first official panel of the conference, you guys. So you'll be joined by myself, Vanessa Moldovan, Leslie Bowles, Carlene Dietrich, and we also have Grabiella, you saw earlier, and Brianna Dwyer. We have a full revenue cycle panel. So stay tuned. We're very excited. We'll see you in a few. Thank you.
Take care, everybody. And I will stick around just in case people were too shy to ask questions with Jennifer there. Can't imagine that would be the case. But I'll stop the recording.